Welcome back to our explainer series, Decode Healthcare with Harshal. Today, we are crossing a literal life or death physiological boundary. You see, in clinical documentation, there is a massive, incredibly high-stakes difference between the alveolar capillary membrane collapse we see in ARDS and the ventilatory pump failure that drives hypercapnic respiratory failure. Confusing these two, and specifically swapping the J80 code with the J96.01 code, doesn't just paint the wrong clinical picture, it actively triggers major hospital DRG denials and compliance audits. Now, back in part 4, we navigated the intense world of electrical and vascular cardiac emergencies. But today, we're shifting gears to critical pulmonary failure, and we're going to unpack the absolute strict guidelines you need to accurately document and code these events.
So here's our roadmap for today's explainer. First, the critical pulmonary boundary. 2, decoding ARDS pathophysiology. 3, the ARDS management pyramid. 4, hypoxemic versus hypercapnic failure. 5, ICD-10 CM coding mastery. And finally, 6, critical coding pitfalls. Let's get right to it.
All right, let's dive into section 1, the critical pulmonary boundary. Look, we've got to set some really strict clinical boundaries right out of the gate, from the very first moment a patient is evaluated. By definition, a life-threatening acute condition is an illness or injury with an immediate risk of death or severe disability. These aren't minor issues. They demand urgent intervention, intensive monitoring, and incredibly rapid care. In the pulmonary system, this is marked distinctly by unstable vital signs. We are talking about massive red flags here. A respiratory rate over 30 breaths per minute, irregular or agonal respirations, and crucially, an oxygen saturation dropping below 90% even when they're on oxygen therapy. When you see these signs, this isn't just a bad cold. The patient's critical systems are actively failing, and immediate intervention is simply non-negotiable. Moving right along to section 2, decoding ARDS pathophysiology. So that urgent clinical presentation brings us to the microscopic battlefield of acute respiratory distress syndrome, or ARDS. Picture the stark difference between normal healthy alveoli and fluid-filled ARDS alveoli. ARDS is characterized by diffuse alveolar damage and severe capillary permeability. The alveolar capillary membrane is essentially collapsing, and that leads to non-cardiogenic pulmonary edema. It's like a wall being built out of thick inflammatory fluid, physically blocking oxygen transfer. It is a complete diffusion failure. Oxygen simply cannot cross into the bloodstream, literally no matter how much supplemental oxygen you provide. Because of that complete structural collapse, the clinical features here are, frankly, extreme. This is a severe inflammatory lung condition with a terrifyingly rapid onset. It presents with what we call refractory hypoxemia, meaning the oxygen blockage resists standard oxygen therapy completely. And ARDS doesn't usually just happen in a vacuum. It's directly linked to other underlying critical illnesses. Conditions like severe sepsis, pneumonia, or aspiration, they trigger this massive systemic inflammation that ultimately destroys the alveolar membrane. It's a really terrifying cascade, which is exactly why these patients require immediate, highly intensive care. Which brings us to section 3, the ARDS management pyramid. So how do we actually fix this without causing even more lung damage? Well, we rely on a very strict, evidence-based management pyramid. Interventions are stacked sequentially. You move from the foundational requirements with the absolute strongest clinical evidence at the bottom all the way up to advanced protocols at the top. Let's break this down step by step. The absolute base of the pyramid is lung protective ventilation. This means using mechanical ventilation with very low tidal volumes, specifically 4 to 8 milliliters per kilogram of predicted body weight, along with a really careful titration of PEEP to prevent further stretching and tearing of those super fragile alveoli. Moving up to the middle tier, we have prone ventilation. Simply placing the patient face down dramatically improves ventilation perfusion matching, or VQ matching, which basically allows the healthier parts of the lungs to oxygenate the blood much more effectively. And finally, at the top tier, we implement conservative fluid management. We want to keep the patient's fluid levels carefully restricted to keep those damaged lungs as dry as possible, right alongside supportive ICU pharmacotherapy to reduce that fluid buildup. All right, section 4, hypoxemic versus hypercapnic failure. Now, ARDS is a specific, devastating condition for sure, but we need to pivot and look at the broader categories of general respiratory failure, because establishing the clinical contrast between these types is a foundational skill every single documentation specialist and coder has to master. So anchor your attention strictly on these hard arterial blood gas, or ABG, thresholds. For hypoxemic respiratory failure, that's type 1, The diagnostic criteria requires a PaO2 of less than 60 millimeters of mercury, usually with a normal or low PaCO2. Clinically, you're going to see severe shortness of breath, central cyanosis, and confusion. For hypercapnic respiratory failure, or type 2, the threshold is totally different, a PaCO2 greater than 50 millimeters of mercury. Here, patients show up with morning headaches, progressive drowsiness, asterexis, which are those hand-flopping tremors, and flushed skin. The causes are night and day, too. Type 1 is often driven by pneumonia or ARDS, while type 2 is driven by COPD exacerbations, severe asthma, or neuromuscular weakness. And these diagnostic differences aren't just arbitrary numbers. They are rooted in entirely distinct mechanical failures. The mechanism of type 1 is an alveolar diffusion failure. Oxygen literally cannot cross into the blood, which is why it's treated with heavy oxygen therapy and mechanical ventilation. Type 2, on the other hand, is a ventilatory pump failure. The patient has inadequate minute ventilation, meaning they physically can't breathe fast or deep enough to blow off carbon dioxide, leading to severe CO2 retention. This is exactly why the treatment pivots to non-invasive positive pressure, like BiPAP or CPAP, to help blow off that CO2, escalating to intubation if refractory, alongside bronchodilator therapy. Let's shift gears to Section 5, ICD-10-CM Coding Mastery. All right, here is where the rubber meets the road. Let's walk through the J96 category. As a coder, you're essentially playing detective with the physician's documentation, and you're hunting for two explicit things, acuity and specific type. If the doc writes acute hypoxemic failure, your code is J96.01. If it's acute hypercapnic, it's J96.02. For chronic cases, you utilize J96.11 or J96.12 respectively. And if a patient with baseline chronic failure suffers an acute decompensation, you use the mixed acute on chronic codes, J96.21 or J96.22. Listen, vague documentation simply will not cut it here. You cannot code what the doctor doesn't write.
But wait, what about ARDS? ARDS has its own distinct primary code, J80. When assigning J80 based on the clinical criteria we just discussed, you also have to be hyper-aware of coding guidelines requiring you to document and sequence the underlying etiology, like sepsis or severe pneumonia. And I want to explicitly call out a strict excludes one note here. J80 explicitly excludes newborn respiratory distress syndrome, which is coded as P22.0. Using J80 for a newborn case violates the guideline, and I guarantee it will result in an immediate billing rejection. Oh, and definitely pay close attention to specific guidelines when ARDS is related to COVID-19 or when dealing with post-procedural respiratory distress, because your sequencing rules will absolutely shift.
Finally, Section 6, Critical Coding Pitfalls. Okay, we are officially entering the danger zone. Understanding the codes is only half the battle. Avoiding the common traps is where documentation specialists really earn their keep. When a compliance auditor looks at your chart, they are actively hunting for specific inconsistencies between the clinical indicators and the assigned codes. Minor slips here, they lead to major financial and audit repercussions. So here are the ultimate must-avoid red flags. First, you absolutely cannot swap J80 for J96.0X. If the provider documents ARDS, you code J80, not general acute respiratory failure. Second, a massive pitfall is failing to sequence the underlying acute cause. If that ARDS is driven by severe sepsis, the guidelines demand you sequence that etiology appropriately. Finally, relying on vague terms that force you to default to unspecified codes, like J9690, is basically writing a formal invitation for an audit. You have got to query the provider for the exact type and acuity. Which brings us to a final, pretty crucial question to ask yourself. The boundary between clinical accuracy and a denied claim is razor thin. Are your clinical documentation practices capturing the true, life-threatening severity of pulmonary failure, the exact pathophysiology, the specific ABG thresholds, the correct J codes, or are vague notes and missed exclusions actively triggering an audit for your facility? It is time to apply these exact clinical boundaries to every single chart you review. Thanks so much for joining me on this explainer, and keep decoding the details.